The ins and outs of dynamic magnetic resonance imaging for female pelvic organ prolapse. Pelvic organ prolapse can affect up to 40% of postmenopausal female population, with 38% of these women having concurrent pelvic organ prolapse and rectal prolapse. Particularly with multi-compartmental prolapse, a multidisciplinary approach is imperative in the workup and determination of the best surgical treatment for these patients. Dynamic MRI has become the preferred modality of choice for evaluation, particularly for posterior compartment disorders. In 2017, the European Society of Urogenital Radiology and the European Society of Gastrointestinal and Abdominal Radiology published a joint recommendation outlining indications, standardized preparations and sequences, and appropriate assessment for MR pelvic floor imaging. We present different indications for dynamic pelvic magnetic resonance imaging, the recommended preparations and sequences, and the identification of reference standards with clinical application to pelvic organ prolapse scenarios. Dynamic MRI can be obtained either supine in a closed magnet system or sitting in an open magnet system. While the open magnet system, with the patient seated upright, is more physiologic, studies regarding image quality between the two options have yielded mixed results. We present the more commonly available closed magnet system at our facility. 100 milliliters of warmed ultrasound gel is introduced into the rectum. The vagina can also be filled with 10 to 20 milliliters warmed gel to provide additional contrast between compartments. The patient is then positioned in the supine position with the diaper in place. Dynamic imaging is performed using a balanced, steady-state free precession sequence to obtain cine images in the mid-sagittal plane at rest during maximal sphincter contraction, straining, and defecation. Several lines for characterizing pelvic organ prolapse have been proposed. The pubococcygeal line, or PCL, has the highest inter- and intra-observer reliability of MRI-based reference points. It is obtained in the mid-sagittal plane at rest, with a line drawn from the inferior border of the pubic symphysis to the last coccygeal joint. The hiatus, or H-line, demonstrates the anterior-posterior width of the levator hiatus and is obtained in a mid-sagittal image with a line drawn from the inferior border of the pubic symphysis to the posterior wall of the rectum at the level of the anorectal junction. The muscle, or M-line, represents the vertical descent of the levator hiatus and is drawn perpendicularly from the PCL to the most posterior aspect of the H-line. The H-line should not exceed 5 centimeters and no more than 2 centimeters in length for the M-line during the maximal strain sequence, respectively. In this patient at maximal strain, the H-line measures 9.6 centimeters and the M-line is 6.8 centimeters. The anterior and middle compartments follow a rule of 3 in grading prolapse. Prolapse extending less than 3 centimeters below the PCL is mild, between 3 to 6 centimeters below is moderate, and extending greater than 6 centimeters below is severe. Here is an example of a moderate cystocele, with abnormal descent of the bladder and bladder neck 4.2 centimeters below the PCL. This is due to a loss of endopelvic fascial support, specifically Delancey level 2. Anterior compartment prolapse can be associated with overactive bladder, sensation of incomplete emptying, with potential for urinary retention and renal compromise if prolapse is chronic and severe. This patient also has uterine prolapse, caused by defects in Delancey level 1 support involving the apical suspensory ligaments, with the cervix 4 centimeters below the PCL. In addition to feelings of bulge, middle compartment prolapse can also lead to dyspareunia. Anterior and middle compartment defects can be treated with a vaginal pessary or surgically corrected via cystocele repair and apical suspension procedures, respectively. Apical suspension procedures include transvaginal or abdominal approaches with or without hysterectomy and/or mesh augmentation. Herniation of other tissues for the vagina, such as the small bowel, enterocele, peritoneum, peritoneal seal, and the sigmoid colon, sigmoidocele, can occur. This patient had previously underwent a sacrocolpopexy for prolapse symptoms, however developed subsequent defecatory dysfunction. Follow-up MRI demonstrated an enterocele, for which she underwent a laparoscopic Moskowitz enterocele repair. Posterior compartment abnormalities include rectocele and rectal prolapse. These patients can present with a range of symptoms, including constipation and incomplete evacuation requiring digitation to fecal incontinence. Radiographically, a rectocele is graded as small if less than 2 centimeters wall protrusion, moderate between 2 and 4 centimeters, and large if greater than or equal to 4 centimeters. Here we see a patient with an anterior rectocele measuring 3.4 centimeters. Correction of pre-existing constipation and surgery via transvaginal rectocele repair to correct rectovaginal and Delancey level 3 defects is recommended. Rectoceles up to 3 centimeters, however, are commonly seen in asymptomatic women. Rectal prolapse is a disease spectrum defined as full-thickness rectal wall prolapse involving the mucosal and muscular layer. This patient demonstrates a rectal prolapse measuring 4.9 centimeters. Rectal prolapse can cause mechanical obstruction to stool passage, as well as fecal smearing and leakage. Left untreated for a period as short as 2 years, permanent damage to the pudendal nerve can result, causing fecal incontinence even after surgical intervention. Surgical interventions include transvaginal and abdominal approaches, with or without sigmoid resection and or mesh augmentation. Descending perineal syndrome consists of descent of the anorectal junction greater than 2.5 centimeters from the PCL. Here we demonstrate descent of all 3 compartments at max strain. Dynamic pelvic MRI can also evaluate functional disorders such as paradoxical contraction of the puborectalis muscle, otherwise known as dysynergic defecation and anismus, where involuntary pelvic floor contraction prevents normal evacuation. Normal evacuation is demonstrated here. The rectal angle at 113 degrees at rest becomes more oblique at 144 degrees with maximum strain. This angle would not change or become more acute with anismus and is also associated with a lack of pelvic floor descent, as well as prolonged and an incomplete evacuation. This video discussed the different indications for dynamic pelvic MRI and the recommended standardized preparations and sequences. We also presented information and techniques for basic interpretation with application to different clinical prolapse scenarios. What is deemed normal measurements by existing guidelines is actually exceeded in 1/4 of asymptomatic patients. And findings must always be correlated to the patient's clinical symptoms and physical exam, especially for patients who present with concurrent urogynecologic and colorectal concerns, who had previous pelvic reconstructive surgery, and when clinical symptomatology does not correlate with physical exam, pelvic dynamic MRI is a useful adjunct and can help guide patient management. It is critical for pelvic reconstructive surgeons to be familiar with this imaging modality to properly counsel patients regarding its process and accurately interpret radiographic findings.